Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to this session in the Cornea series to the Wonderland. And it has been a long time before we are lucky to have Dr. Nancy Al-Raqqad with us. So we are delighted to welcome her in this distinguished session, actually, because the topic is very unique. And everybody knows Dr. Nancy Al-Raqqad, no need to introduce her. She is head of cornea specialty in Jordan, in King Hussein Medical City. And she is consultant cornea, cataract, and refractive surgeon. She is a pioneer in the field of cornea, keratoplasty, and keratoprosthesis. So thank you very much, Dr. Nancy, for accepting the invitation and for being with us. Now, the stage is yours, and you are most welcome.
Thank you very much, Dr. Mazen, for this introduction. The honor is mine, honestly, to be part of this very high impact and prestigious academy. The topic, as you said, is unique in many aspects. First, the surgery is unique, the patients are unique, and the doctor has to take a unique time in order to address such a procedure. So before I start, I want to say, always I believe in something that if you do not have a past, you cannot build a future. And that's why, and this is the message that I say to everybody that find such challenging procedures, difficult to adjust and difficult to uptake in their practice. And when we look back at the history, when Edward Zerm in 1905, he implanted a square corneal transplant, and now we look back and say, oh, he must have been crazy. And but this square transplant has changed the whole face of corneal transplantation. And this is how I look at keratoprosthesis, honestly. So it's a future for many things. And also, before I start in depth, I want to talk about flashbacks of a penetrating keratoplasty started in 1905. And now we're talking about selective corneal transplantation, about lamellar transplantation, the deep anterior lamellar, the DSEC, the DMEC, the DWEC. All these, the aim is to selectively transplant the diseased part and tissue to decrease the risk of rejection. And these are, we're talking about the best option when the environment of the eye is optimal. The drawbacks are the scarcity of the tissue, the rejection rates, and as we said, the sources for tissue preparation. And they cannot be amenable in some cases where the hostile environment is present in the eye. And in cases of desperate corneal blindness that conventional keratoplasty cannot withstand. And this is where keratoprosthesis comes in. And I look at keratoprosthesis as a transformative procedure. It is not a therapy that we offer patients in order to replace the diseased tissue. It is a transformative procedure that transforms the disease, the environment of the anterior part of the eye. So it's not an effort to replace it, or replace the cadaveric corneal transplantation, or to replace the source of tissue if it is scarce. The aim is to bypass the ocular surface and cornea and the hostile environment. And it is used in desperate cases with multiple comorbidities. It's never a magical spell. It's a helping hand in the right time and for the right people. Now, let's go to basics. The artificial cornea or the keratoprosthesis, it's plastic. It's an artificial with an artificial optics. So there's no epithelium, and we don't have to worry about problems with the surface of the cornea. There's no endothelium, so there's no rejection fear. And the concerns are only the retention rate and the biointegration of the material. And because this is a static tissue, let's say, there's a loss of defense mechanism as compared with the normal cornea that integrates and becomes part of the body. And if we have a look about the types of keratoprosthesis, we have a lot of types nowadays, and we can divide them into two major types. Those that need biological support or rely on biological support, and those that do not have a biological support. The biological support group is the osteoodontic keratoprosthesis group, or the modified OOKP, and it can be taken from a tooth root, a tibial bone, or a cartilage. Now, the non-biological support depend on artificial material, and it includes the PMMA, that's the Dolman Duane or the Boston, with its two types, type 1 and 2, the Pentushi, the dark, which with its dacron constituent, the Alpha Core with the hydrogel implant, and the hydroxyapatite, the Leon Barricade, which is also the hydroxyapatite constituent substance. But among all these that I've shown, there are only two winner devices. And when I say winner devices, I mean two sustainable, biointegratable with high retention rate. One is the osteoodontokeratoprosthesis for the dry, non-blinking, keratinized eye or that has a lid defect, and the Boston type 1 keratoprosthesis for the wet blinking eye. And there is some integration and overlap between these two devices. So I will concentrate about these. Now, for the general population and for the general ophthalmologists who are watching this and want to refer a patient for keratoprosthesis, it's very important to remember these patients have special needs, and these eyes are desperate eyes. So it's important to assess the visual potential thoroughly, and I mean taking history when the visual the poor visual acuity dates back, because this could be an amblyopia eye. Is there a projection of light in 4 quadrants or not? You have to do an ultrasound to check the posterior pole. Sometimes you have to go into endoscopic endoscopic visualization of the inside of the eye to make sure that it can benefit from the procedure. VEP, ERG to check the electrophysiology of the eye. If the patient is diabetic, make sure that he is under strict control, because all this affects the visual prognosis, because you're offering a difficult surgery. It's not a normal surgery that you want to proceed with. These patients also have comorbidities. So remember, these patients have local and systemic diseases, and they will affect the outcome, they will affect the management, they will affect the complications. Important to address in your trade time. These patients need longer commitments. It's not, we say to keratoplasty patients, it's not a phaco that we implant a lens and you can be discharged after 1 month from the clinic. This is for the keratoplasty. For the keratoprosthesis patients, we say this is a long-term relationship. So you get married to the ophthalmology clinic, honestly. So if they are not able to commit to visits, it's not worth it to undergo such a procedure. Strict compliance, because if you need compliance to take care of a normal corneal transplant, you need 10 times that compliance to take care of a keratoprosthesis. It's important for the surgeon or the doctor to understand why are you offering it to the patient before offering it. So if the patient is happily adjusted, or the patient has one eye that he's seeing with and mobilizing and everything is fine, it's not important, and it's not logic to offer that to the blind eye or the eye with the poor visual acuity, the other eye with the poor visual acuity, as long as the patient can mobilize himself with a good seeing eye. It's important also to address the challenges for the patient. It's important also before going to surgery to optimize the surroundings of the eye. So chair time is crucial. It's very important that you dedicate some time to these patients who are counseling for keratoprosthesis and also undergoing keratoprosthesis. So the double effort is compared to the natural corneal tissue, whether it is from the surgeon or from the patient himself. Let's go to indication. When would you refer a patient to keratoprosthesis? First, and the best option and the best patients who would do well with keratoprosthesis are patients who have multiple graft failure, and they carry best prognosis because the environment is much favorable. Sometimes we say after the 3rd graft, we go for keratoprosthesis, which is the Boston type. Sometimes some patients, they come after the 10th graft. So because sometimes psychologically they want to just keep trying to implant a graft, and but these are extremes. So we usually do it after the 4th or the 3rd graft. A Kipro. Now, if there's a neovascularization, whether it was a previous infection, a rejection, or a stem cell failure, or a chemical burn, or limbal stem cell deficiency, all these are an indication to do a primary keratoprosthesis, because we all know that a neovascularization, especially if there's a stem cell deficiency, a normal corneal graft would not be maintained and will not survive. Mucous membrane pemphigoid is also one of the indications. Ocular mucous membrane pemphigoid is one of the indications to undergo keratoprosthesis, because, as you say in the first photo, it's a very hostile environment with adhesions, symblepharon, ankyloblepharon, keratinization, and usually we can offer either the OOKP or the Boston keratoprosthesis for these kind of patients. One important point that I want to highlight is that these patients are scarred physically. and they are scarred emotionally and psychologically. So if you want to offer it, you have to be up to it, and you have to explain a wide range of expectations and complications and commitment. So it's not only doing a procedure that you have to master. As a surgeon, you have to rise up to the challenge. Let's talk about the Boston Keratoprosthesis. Now, the Boston Keratoprosthesis, because it's originally made and manufactured in Boston, and the attribute goes to Professor Klaus Dolman, who turned 100 years old a few months ago. And this is a tribute for him, to be honest, because the Boston Keratoprosthesis has been a life changer and a game changer for a lot of patients all over the world. And it comprises two parts: the anterior optic, which is a 5mm optic, and a posterior optic, which is an 8.5mm in size. And between them, you see it as a nail, and between them there is a sandwiched a normal cornea, and that we suture it to the healthy living tissue, or the living tissue, not necessarily healthy. Now, the procedure with the Boston Keratoprosthesis needs skills that are a step further than penetrating keratoplasty. You need skills to adjust and to assemble the keratoprosthesis lamina, let's say, the device on the side table, and then we prepare the eye. Usually we take an 8mm trephination. We do an open sky ECCE and anterior vitrectomy most of the time. Sometimes we leave the eye, if it's pseudophakic, we leave it with the lens in. But most of the times, especially in our part of the world, the patients that come, they have a very opaque cornea, and you cannot see the status of the lens, and the patient does not remember if he had a cataract surgery with the lens or not. So we just, let's say, and we take out the IOL, even if we open the eye, when we do a limited anterior vitrectomy, and we order a K-Pro that has some power, because the anterior optic is measured according to the axial length, and it acts as a lens, and the cornea at the same time having some refractive power in it. It's not only a PMMA optic. And sometimes if the iris is in a good state, we do PI or sphincterotomy to remove it out of the way and to decrease the possibility of glaucoma. And we suture it like we suture a normal penetrating keratoplasty with 10 eyeliner sutures all around, and we add a contour lens that comes with the device. And the idea from the lens is to bath the eye with the lubricant eye drops in order to, and this stays for life, in order to just keep it moistened. The more moistened it is, the more it will be retained and it survives. Now, sometimes we take the Boston Keratoprosthesis a step further. And in this regard, I mean, we reconstruct the anterior segment in cases of severe disorganized bulge that we cannot put a corneal transplant, and the eye is severely disorganized and bulging and lost all its geometry. We use the Boston Keratoprosthesis in order to implant it and give back the shape of the eye again with the anterior optic seeing through. And sometimes even in cases of severe limbal stem cell deficiency and chemical burns, in order to revive the tissue again after inserting the Boston Keratoprosthesis, we add some simple limbal epithelial transplantation, or either at the same time or beforehand, to give some viability and some to the tissue that's surrounding the Boston Keratoprosthesis. And let's talk about the success rate. Now, in normal corneas, the success is defined as the clarity of the cornea and decreasing the rate of rejection as much as possible. Now, when we talk about the keratoprosthesis, especially the Boston Keratoprosthesis, there's no means of talking about rejection. The success rate is defined as in retention rate and in managing the complications. So retention rate is very high. It's up to 85% over 15 years in the Boston Keratoprosthesis. But given that the environment is, as I said, optimum, moistened, the eye is moistened, it's kept preserved in the optimal way possible. But what are the complications or the problems that we might face? And we see this quite common. Now, the most common complication that you see in patients with Boston Keratoprosthesis is the retroprosthetic membrane. And it is similar to an inflammatory membrane that you see behind the optic, but it's not inflammatory. It is it's a reaction from the iris tissue that you stretch during surgery and do sphincterotomy. So they grow some tissue sometimes behind the optic. And it's very important to YAG this as soon as you see it forming, because if it took a long time to act on the retroprosthetic membrane, the YAG laser will not be able to take care of that, and you need to go with a cutter with a limited pars plana vitrectomy and do a cutter and just cut the membrane behind the optic. And this is one of the most common complications that is encountered. Now, the second common complication is a glaucoma. And the problem with the glaucoma in these patients is that you cannot physically feel the intraocular pressure because the optic is not indentable as the normal cornea. You can indent the sclera. You can teach the patient how to measure his IOP compared with the other eye, let's say if it's normal, or compared with other eyes, to just appreciate how much the eye is firm, rigid, or soft. And this comes with experience. Now, the second thing that you have to do is a serial optic disc OCT in order to detect any changes in these patients. Now, the recommendation that we say in patients with the glaucoma is that if you suspect a patient who has glaucoma, or that you find that the anterior chamber is collapsed and the angle is collapsed and there's no way there will be drainage of the aqueous humor, it's very important to implant at the same time of surgery or afterwards an Ahmed glaucoma valve. And this is a routine now and a recommendation for patients undergoing keratoprosthesis who already have or are suspects of glaucoma or high intraocular pressure. The second or the third complication that we might face in these cases is the melt or the extrusion of the device. And this happens especially if the environment becomes very dry, especially in keratinized patients, and especially if the contact lens just falls and the patient does not pay attention. They are absent to clinical visits, and they just suddenly come out with the prosthesis sticking through the anterior part of the eye. Now, the good thing that we've never seen a prosthesis that is, sometimes we see melt and perforation in cases of corneas, normal corneas, whether due to its infection or a trauma or whatever. In cases of keratoprosthesis, we see extrusion. We've never seen a complete perforation because somehow the Boston keratoprosthesis has 16 holes all around in the posterior part of it. And these holes, they just integrate tissue. So the tissue just gets stuck to these holes. And even if there is melt in the anterior part, the posterior part just keeps sticking in. And the action that we need to take is just to revise the surgery, take out the prosthesis, dismantle it, put it back in another cornea, and transplant it again. And that will last the patient for a longer time as well. Now, the worst retinal detachment also is one of the very, very rare things that you might see in cases with Boston keratoprosthesis, and also choroidal effusion, and this can be at the beginning of the surgery managed with a high dose of steroids, systemic steroids. Now, the most doomed complication that might happen is infection or endophthalmitis, and as bad as it is in the normal eye post-operatively, the endophthalmitis that happens in a patient with keratoplasty is just so destructive to the patient because he lost just the last chance he has to see. These patients have gone through a lot to be able to regain sight, and if the infection comes, they've just lost that winning paper, let's say, or winning card. In cases of one particular thing that I need to mention is that these patients, they should be on antibiotics for life, topical antibiotics for life, and this should not be stopped at all. And I think in order to discourage resistance, we just alternate the antibiotic types of drops every month, 2 or 3 types of antibiotic drops. We alternate them in order to decrease the risk of resistance. And the second thing is that whenever you just any pain, we tell the patient any pain, any change in vision, anything that's abnormal that you feel, you have to run to the hospital, and we treat any sign of infection as endophthalmitis, and we treat with vigorous regimen unless proven otherwise. Okay, let's talk about latest advances in Boston keratoprosthesis. As I said, Boston keratoprosthesis has been a game changer over a lot of years in the past. Now, they have designed a new design that gives the Boston keratoprosthesis a color. So there are the brown, it's called the Lucia design, and there's the brown, the blue, and the green color, so the patient can ask for what kind of color he wants in his eye. Because in the past, it used to be either titanium with a metallic plate sticking out of the eye, or if we put the PMMA plate, it just the see-through, the cornea looks like a little pale blue, and the patients do not like that, especially if the other eye is brown. So now the Lucia design comes with a flowery petal-like openings in the back, and it gives they can just color the back plate with the three different colors that are changers for the patients. The other thing that is an advanced that's working on it in the Massachusetts Eye and Ear Infirmary is the pressure sensors. Now there are special pressure sensors under study to be transplanted along with the Boston Keratoprosthesis to give us to read pressures and to give a serial pressure reading over the weeks for the patient and the physician. And this will be also a game changer. And they're working also on exploring different materials that last longer than the PMMA or the titanium material that is used in the Boston Keratoprosthesis. I just want to say, after implanting 100 K-Pros last month, I was looking back at all the patients we had treated in the hospital, and there were times of melt. We had patients who had melt, and we were able to rectify and to revise the graphs. And this is maybe a message to all the physicians or the ophthalmologists who find it discouraging to send any patient, to refer any patient to undergo the surgery, and they discourage the patients to undergo this kind of procedure. And maybe this is a message to this kind of reluctant doctors. When we look back, we did have times of melt that were rectified and the grafts were revised. We had times of infection that was treated. We had choroidal effusion that was reversed. We had extrusion that was reversed also, and we had a retroprosthetic membrane that was yagged. But among all the 100 K-Pros, we saved more eyes and lives that we have lost. And so it is used to be, and it still is, a game changer point in the lives of a lot of patients after all. So this is concerning the Boston Keratoprosthesis. Now I want to talk about a more advanced and more aggressive kind of keratoprosthesis, which is the osteoodontokeratoprosthesis. And this is a tribute to my mentor, Christopher Liu, who could not be with us here tonight. I always bow in front of him as a mentor and in front of the procedure as a procedure. Now, the osteoodontokeratoprosthesis is known as the tooth in the eye, and it is literally a tooth taken out from the mouth and stuck in the eye. It's a surgery that's described over 40 years ago. It remains the keratoprosthesis of choice for end-stage corneal blindness, not amenable to penetrating keratoplasty. It was first introduced in 1963 by Strampelli in Italy, and then Falcinelli, which was his son, modified it in 1973, and this owes to the day's success in modifications in the osteoodontokeratoprosthesis. And then in 1996, Mr. Christopher Liu introduced after spending 3 years learning the procedure in Italy, he introduced it to Brighton, which used to be the National Referral Center for the Keratoprosthesis in UK, which unfortunately now moved to London instead of Brighton. And I had the honor and a pleasure to introduce this kind of technology to Jordan in July in 2016. Now, the keratoprosthesis, which is the osteodontokeratoprosthesis, needs two teams. It's not only the ophthalmologist, it needs also a maxillofacial surgeon working on another table and the ophthalmologist working on one table. Why is that? If you can have a good look about this photo, and you can see a keratinized, severe symblepharon, severe adhesions, disorganized eye. And these usually do not survive the Boston keratoprosthesis, which seems very simple in front of the osteodontokeratoprosthesis. So these kind of patients, they have to go the OKP, which have a higher retention rate. And the osteodontokeratoprosthesis occurs over 2 stages, which are 2 to 3 months apart. Now, the first stage, the lamina is taken out from the patient's own tooth. And I apologize for this aggressive photo. The canine is taken up to the root bone, extracted through the maxillofacial team, and then it's grounded into a block in order to reach as thin as possible, as small as possible, without breaking the bone. We don't need the teeth, we need the root of the tooth, which is the canine. And why the canine? Because the longest retained body in the human being. So everything resorbs except the canine. It stays forever. And it takes few hours to fashion a lamina. As I just want to give you an insight how the lamina is fashioned. As thin as possible, it becomes 3 millimeter in thickness. And after fashioning the lamina, we ask the maxillofacial team to drill a 3 millimeter hole in it, and we keep just watering it. We just put the saline for the maxillofacial team in order to drill a 3 millimeter hole. And this is how it goes. There's a 3 millimeter hole in the bone, in the bone of the canine. And on the other slide, you can see the small optical cylinder. This optical cylinder has a power, and it's produced by the Mortar company. And that you put it in the hole, in the 3 millimeter hole, and they use cement in order to make it adhesive to the bone around it. So this is what we call the OOKP lamina. It's literally an optical cylinder inside the tooth root that is fashioned into a very thin 3 millimeter, 10 millimeter long, 3 millimeter height lamina. Now this procedure takes 2 to 3 hours. Now after that, we put the OOKP lamina under the eyelid. We bury it under the eyelid for 2 to 3 months for 3 reasons. The first, because you took the tooth from the mouth, so any infection in the oral cavity just becomes released in the skin. This is the first thing. The second thing, it's very sharp edges, so it acquires soft tissue by burying it underneath. And also, at that time, you just give some time to the eye to be rehabilitated before you implant the osteoodontal lamina in the eye. Now, the second stage is where the ophthalmologists do all the work. And so, in the first stage, you put a buccal mucous membrane and cover the eye after removing all the adhesions, sometimes doing fornix reconstruction, working on the eyelid. You can get help from the oculoplastic team to work on the eyelid and to facilitate opening the eye, and the buccal mucous membrane covers the whole eye. Now in stage 2 OOKP, we just reflect the buccal mucous membrane, we open up the cornea 3 millimeter, we take out the iris, we take out the lens with the intracapsular cataract extraction, we do an anterior vitrectomy, and then we place and then we take out the OOKP lamina from under the eyelid. We irrigate it with some antibiotic saline, and you see here in the first slide that now it has it was a block of bone. Now it has some soft tissue around it. It's more softer now. And after opening the cornea and reflecting the tissue of the buccal mucous membrane, we use this block and put it on the eye, and we center it in the central part. And we use a lot of suturing skills in order not to tangle the vicular sutures and the 1009 sutures, and we put it over the eye. And after that, we reflect, and voila, you see this is where the optical cylinder sticks in the middle, and the eye is transformed forever. And this is a schematic diagram of the osteodontal keratoprosthesis and the changes that occur to the anterior chamber structure. So if you look at a cross-sectional diagram, you see that the eye becomes aniridic, aphakic, compared to the anterior chamber. It loses all its features. So there's no limbus that you can look at. There's no cornea that you're used to. There's a buccal mucous membrane covering a tooth, the tooth holding an optic, the optic hanging in the used to be corneal tissue in order to reflect. And after the surgery, we make sure that we centralize this so that into the macula that the patient has as the final result of the osteodontal keratoprosthesis eye looks like. It looks alien-like, and this is some of the things that you have to tell to the patient, but it moves the patient from a dependent person into a mobile person. Now let's talk about limitations and complications. For oral surgeons, it's mouth-related problems, the buccal mucous membrane, if there are scarring, difficult opening of the mouth, sometimes bone breakage, and they have to just implant a bone graft in the place of the defect. And sometimes if the patient does not have good teeth, we take it from the next living donor, his children. If he doesn't have, we take a tibial bone, but it's not as surviving as the canine. The eye-related problems, we have sometimes early problems such as buccal mucous membrane necrosis, and we had this in the first case that we could rectify and repeat the buccal mucous membrane, because if you make it a bit thick, it will be necrotic. Thinning, as we said, overgrowth sometimes that's just bulge. You have to scoop it and decrease debulk it. Later on, sometimes the tooth resorbs, and if the tooth resorbs, the optical cylinder becomes very mobile, and this allows bacteria and microorganisms to go through, and this puts the patient at the risk of infection. So that's why, or extrusion. So this has to be revised again. Endophthalmitis is also a risk, although it is less. It's less of a risk in OOKP than the Boston keratoprosthesis, because the buccal mucous membrane just is defense mechanism. Glaucoma also, it's one of the most important things, and you cannot put an Ahmed glaucoma valve, you cannot implant anything for these patients, and the drops, they cannot go into the eye. So how we manage glaucoma in these cases is that we let the patient put the drops, anti-glaucoma drops, under the eye, under the tongue, to allow some systemic absorption. And if we talk about cosmetics, the eye does not look very nice after all. And these patients have to go on acetazolamide or Diamox for life. So if they have any kind of problems with that, you cannot undergo the surgery just because they cannot control the pressure afterwards. One message that I want to convey is that it's very important to choose the candidates carefully. Either it's in the Boston keratoprosthesis or the osteoodontal keratoprosthesis, because they have to commit to lifelong follow-up. Please don't touch the happily adjusted blind. Don't touch patients who are younger than 17. You have to make sure that the posterior pole is normal, especially in the OOKP, because it's a big procedure, it's a long procedure, it's a hazardous procedure, and they spend like 16 hours under general anesthesia, 8 hours on average on each session. So if there's no visual potential, there's no need to put the patient under this risk. Please make sure that the patient has reasonable expectation and they have no problem with how they look. Talking about the success rate is defined in terms of detention. The longest lasting K-Pro is the OOKP, with 85% in 18 years, with 75% of patients seeing 6-12 or better. That's given that the posterior pole is good. And although it is far from perfect, keratoprosthesis is the only hope for restoring sight in the long term for desperate cases, for those that are not amenable to conventional corneal surgery. And my take-home message is, first, these are desperate anterior segment cases with normal or good posterior segments can benefit a lot from K-Pros. You have to know the visual potential of the patient before offering him a K-Pro. Make sure to spend time explaining the procedure, the risks, the benefits, and the need for long life commitment to clinical visits. Do not force K-Pro on the happily adjusted line or the patient with unreasonable expectation. Teach your patient that every single day is a bonus and the vision lasts as long as the K-Pro lasts. And because with keratoprosthesis, it's all about obstacles, I just want to say that one of our Boston patients has been blind for 30 more years and now he has a driving license. And one of our OOKP patients saw his grandchildren for the first time after 15 years of blindness. It is difficult surgery and they are difficult eyes, but yet rewarding for those in desperate need. And sometimes it's our mission to spread knowledge, and it's better to light a candle than curse the darkness. And thank you very much, and I'm open to question. And this is a tribute to Christopher Liu. This goes back to 2009 when I started learning keratoprosthesis at Brighton and Sussex Eye Hospital. Thank you.
Thank you very much, Dr. Nancy. Actually, a very nice presentation, very informative, and many congratulations for the great achievement, the 100 keratoprosthesis. That's a great experience, actually, that we can learn a lot from. Before we go to the questions, actually, I have a very, very limited experience in the keratoprosthesis. I did only 2 cases with a very early alpha core, and that was about 15 years ago. Both they failed, actually, with melting. So I have bad experience with this. So do you agree with me that maybe you have some experience with the alpha core?
Yes. Now the alpha core, I did not use it in Jordan, but I used it when I was in UK. The problem with the alpha core is the material, and that's why we said the Boston and the OOKP are the winner devices. And when we say winner in terms of retention, Sometimes you do a perfect procedure and a perfect surgery and a perfect outcome, and then the patient comes after 1 year with a melt or an extrusion. And this is very disappointing. And sometimes they do not notice. Sometimes these patients do not notice that's melted. They don't run to the hospital at the first sign, and they come not only with a melt, with a soft eye, and then you have a lot to save, and it becomes disappointing. And it's not only you, Dr. Alaa Dinosauri also. He told me that I stopped when I saw these patients and they coming with melt and extrusion. I just stopped doing that. That's one of the reasons to stay motivated. And as I said, we saw few melts with the Boston K-Pro, but we saw it maybe early that, and the good thing about the Boston K-Pro, that's different from the Alpha Core. As I said, the 16 holes that in the back, I found even if it's extruded and the eye is melted, some tissue is stuck in these holes that it does not allow it to fall out. So we just anesthetize the patient, we take this out, and open sky, we just revise it. And I learned how to dismantle it. So it's like really a screwdriver and a needle, and just dismantle the things, and with and the lock and the ring, and putting it back again in another cornea, and putting it back to the patient. And we had few. I think my fellows are online and watching this now. They know what to do, and they know how to deal with these patients. And sometimes we don't panic with a K-Pro extrusion in the Boston as we panic with a normal cornea, because we know it's not going to fall out. It can wait for like next Sunday morning to rectify it, but we can do. It's difficult, sometimes disappointing, but you have to just keep going. These patients, you're their only hope, and sometimes seeing day and light just makes a difference for them. So we just have to fight.
Yeah, great, thank you. Now, a question from my side. Does it differ if the cornea is very thick? I mean, the failed cornea is thick or thin to make a decision to go for Boston, for example. I mean, let's assume that you are doing UBM in order to check the inside the anterior chamber structure, and to see as well if the cornea is not very thin. So do you change your decision if you see that the failed cornea? Sometimes we may see some failed corneas with thin walls. So this is my question.
You mean thin corneas or thin K-Pros? I did not understand it exactly.
Yeah, the graft, the previous failed graft, for example, after 5, 6 times of failure, yeah, the graft, the last graft, for any reason, there was a thinning in the graft itself, and you want now to do the Boston. So any changes in the decision?
Yes. When we do the Boston keratoprosthesis, we used to do or to put it or to support it with a new graft. Okay, so we get a new graft, and this just costs the patient a lot of money to have a new graft, as if we were transplanting a full PKP, and we just put the Boston in it and we suture it. Now what we're doing is that we're using the same graft of the patient. If it's thin, definitely we change it to another. Sometimes we take tectonic grafts that's been like taken for 2 months, and they're edematous a bit, and they gave us some good support and strength. And we use it to exchange it. So if the patient's cornea is thin, we do not change the decision to do a Boston or not, but we change the decision to do this graft in particular, and we use either a new graft from the eye bank or a graft that has been taken out from a patient who has been transplanted recently.
Okay, super. So
because just comment on one thing, the Alpha Core in particular needs a thick graft. That's why the comparison. The Boston does not. That's so if it's an Alpha Core, definitely we wouldn't go for that.
Yeah.
Boston, we wouldn't care. Yeah.
Yes, exactly. This is why I asked this question.
Yeah. Now I just connected it. Yeah.
Thank you very much. So let's see the questions. Fadi Yahya, thank you very much for the detailed explanation regarding the OOKP due to intermittent slow internet connection. Why is the root of the tooth chosen? Any preference which tooth?
Maybe I mentioned that the canine is the last bone in the body, in the human body, to resorb. So when someone dies, they found that the canine just lasts and sometimes they get genetic material from it. So in order to make sure that this canine does not resorb, especially when we remove it from its own host and we transfer it to another person, the bone is not there anymore, and there are no shear forces, so it will resorb and become weak. So they found that the canine bone is the longest lasting bone in the body. Now, if let's say, suppose that the patient does not have good teeth, and because we do x-rays, we do a lot of preparation for the osteodontic keratoprosthesis that I did not mention. The patient is orally rehabilitated for a year before he goes into the surgery. The oral surgeons, they do like frequent visits for the buccal mucosa health, and they make sure that the bone of the tooth is very healthy to be taken. Now, if this is not suitable, they take it from the next living donor. Let's say the family members, the son, the daughter, whoever. And sometimes if they do not agree or it's not suitable teeth, we take it from the tibial bone. But to be honest, the tibial bone, sometimes it resorbs in 1 year. The bone is not that good, and sometimes it's taken from cartilage. So the best is to take a tooth root for these patients. And sometimes when we take it, we used to take 2 bones and we buried the other one in the shoulder, because if anything happens to the first bone, we just take it out from the shoulder, the second one, and we just put it in the eye instead of just going to the surgery and making the max fax to do another oral procedure again.
Yeah, thank you very much. Bayan, thank you, Dr. Nancy, for this informative lecture. Muhammad Amin, 100 BKP, world class, I agree. Zara, thank you. Ihab, thank you. Thanks, all thanks. You deserve the thanks.
We have somebody from Germany, Bavaria. Yeah. I think there's a question and answer questions in the
yes, in the box, yes, in the Q&A box. Muhammad Amin, so sad that keratoprosthesis is unavailable in Algeria. I don't know about the situation in other Arab countries. In Jordan, it's available, of course, and in the Gulf area, it is available. In Syria, it was available. So I don't know how about the Morocco, Libya, Algeria.
No, because I have patients coming from Algeria and coming from Libya and Morocco. They don't have it there. The thing with the Boston keratoprosthesis is that you have to be registered in the Boston study group, let's say, and a known surgeon who does the procedure. So sometimes, even if you ask for it, they wouldn't ship it unless you are vouched for with a known surgeon, let's say. Because I remember trying to get it into Yemen, and they couldn't unless it traveled to Jordan and then shipped there. So it has some politics. And also in Egypt, I was amazed that they could not get the Boston keratoprosthesis into Egypt as well. They have a problem with the grafts too. I think our part of the world is lucky to have this facilitated kind of having it, but you can refer the patient anytime.
Yeah, thank you. Muhammad Amin again, do you do systematically the VAP or ERG before going to such operations to be sure of the function?
Yeah, we do make sure that of the function. Not always we perform VAP or ERG unless we are skeptical. Sometimes if the patient has hand motion or counting finger, this is a very good insight. Sometimes if there's a poor projection of light and not in the 4 quadrants, but the patient is convinced that he has to go into this surgery, and you want to find a good evidence for yourself and the patient, we perform these to make sure that really he would benefit or not. But yeah, yes, of course, you have to do all the checks for the visual prognosis of the patient.
Yeah, another question. Is ONH OCT reliable in case of BKP?
Yes, and this is how we follow up the glucomatous changes in patients who are suspect for glaucoma in patients with Boston keratoprosthesis with serial, so every 6 months, serial optic nerve OCT. And there's a glaucoma also progression program in the OCT that you can just download it and keep an eye on that, because at the very the first encounter of or suspicion, you have to implant a rahmat glaucoma valve. Of course, these patients are on anti-glaucoma drops for life.
Mm-hmm. Okay. When do you choose either whether to go for Boston or the osteo? So are there specific indications that let you choose in between?
Oh, yes. As we mentioned in one of the slides, the wet blinking eye, if there's a normal anatomy of the eyelid and the eye is wet and blinking, then you have to go, or it's better to go for the Boston keratoprosthesis because it looks like a normal cornea after all. The osteodontic keratoprosthesis, it's a very aggressive procedure and it's a very aggressive looking kind of eye. And we only choose it for the very dry, the very keratinized, and the eye that has lost its the geometry and the relationship of its eyelids structure. So on terms of which is more retained, the OO cape is more retained, but the Boston Cape Pro is more common. It's easier. It's easier to perform, and it's better looking for the patient. Sometimes, even if the eye is keratinized a little bit, sometimes I do go for the Boston Cape Pro type 1. There's a Boston Cape Pro type 2 that you can use it in the severely keratinized and you don't know how to do an OOKP. And it has an optic that's very long and sticks out of the eyelid. So you have to tape the eyelid and close it forever. And then the OOKP, the optic just sticks out of the eyelid. But these patients don't know how to sleep, so they have to cover it at night in order not to see light. It's kind of disfiguring.
Thank you. Mohammed Amin, can we refer patients to you, Dr. Raqqad? Yes, of course, I can answer on behalf of Dr. Nancy. And this is what I'm doing actually from time to time whenever I need Dr. Nancy. Thank you.
Thank you.
Now, Mustafa says, when do you choose Boston and when do you, the same question. So you already answered. I think no more questions in the Q&A. We go back then to the chat box. Miroslava, hello from Germany. Blue, Danube, thank you very much. Hajar, thank you for the informative presentation. Any chance to take a course in implanting the K-Pro, even observational, not necessarily hands-on with you or other colleagues?
Of course. I don't know where are you from, but you can. I can write down my email, and you can just email me, and you are welcome.
I think Hajar is from Bahrain, I guess. But however, I think hands-on is very important in such cases. Observation is not sufficient actually, because
Yes.
this is an unusual procedure. It is not the one that you can learn just by observation or watching videos. It needs a lot of skills, a lot of skills, and you need to do a number of cases. It is not only, or maybe wet labs, let's say, because you have to spend sufficient time in observership. It is not only just maybe 1 week and to observe. You have to follow up patients in order to see how to manage after that. Otherwise, you will end up with complications if you don't know how to manage.
Absolutely.
Dr. Nancy, yes.
And one thing I want to add to Dr. Mazen's comment is that you have to be very expert in doing a penetrating keratoplasty, because this is only a step further. You cannot just come and just learn K-Pro from nothing or from scratch. You have to build it on a penetrating keratoplasty skills. So this is my advice. And as you said, it's not only implanting the K-Pro, it's dealing with all the hassle around it and after it. So, yeah.
Exactly. So thank you very much. It was an amazing session, and I enjoyed the discussion, and I learned a lot. And thanks for all attendees and for their lovely questions. If nobody has any question, no more questions, then we are going to conclude. Luai, thank you very much for the interesting presentations. I have a question. How much time to have a full bio integration?
Okay, that's a good question. The normal cornea bio integrates at 1 month. So it takes 4 weeks for the integration to happen in the normal cornea. And I'm talking now about the K-Pro, the Boston K-Pro, it's it's really a normal tissue that's holding the stitches and holding the optic. So it's 4 weeks as well for the biointegration. With the osteodontic keratoprosthesis, it takes up to 2 months for the biointegration between the buccal mucous membrane, the optical cylinder, and all the other constituents of the lamina and the capro.
Okay, great. Thank you very much, Dr. Nancy, for this great presentation. And hopefully we will see you in the future sessions as well, inshallah.
Allah. Thank you very much, Dr. Mazen.
Pleasure. Thank you, everybody, and have a good night. It's still here afternoon here in the USA. I'm in the US now.
Oh, you're in the USA. Okay. Oh.
Yeah.
Okay.
Assalamu
It's a big
alaikum.
effort. Okay, assalamu
Yeah.
alaikum.
Wa alaikum
Take
assalam.
care. Bye. Good night.